Hello and welcome to the latest installment of the Rural Minds Connections webinar series. I'm Julie Lux, Vice President of Communications at Rural Minds, and wanted to start out this evening by telling you a little bit about Rural Minds, and then we'll get into tonight's subject matter. Rural Minds is a 501c3, and we have the mission to serve as the informed voice for mental health in rural America. And we do that through information and resources. And tonight's webinar is a terrific example of that information. Now, I should mention that all of these webinars are sponsored and co-presented by our good friends at the National Grange. And tonight's sponsor for this presentation are the kind folks at Sage and Biogen. So thanks to them for their support. Our subject this evening, at least I find, is going to be a very interesting one. We are going to be talking about managing postpartum depression in rural America. And we have two terrific guests with us this evening. We have Dr. Keisha Callins, and she is an OB-GYN with the Community Health Care Systems. And Keisha will tell us a little bit about herself, a little more about herself here in just a minute. But also with us is Carrie Banks, and Carrie is a peer support program director with Postpartum Support International. And not only is Carrie going to be talking about her organization, but also sharing with us her lived experiences. So I think this is going to be quite interesting. But as usual, just wanted to remind everyone watching that we at Rural Minds take your privacy very seriously. So participants' names nor images will be seen on the screen during this webinar. However, we do encourage you to participate, and you can do so by asking questions. So as you listen to Keisha and Carrie's presentations, please feel free to go to the question box at the bottom of the screen and type in your question, and we will take a number of those at the end of this evening's webinar, time permitting. But speaking of time, let's get right into it. And I'm going to ask Carrie Banks to join us. Carrie, thank you so much for being here. If you would please tell us a little bit about yourself, your experiences, and your organization. And I'm going to turn the floor over to you. Welcome.
Great. Well, thank you so much for having me. I'm really happy to be here. Happy to share my lived experience and also some information and resources from Postpartum Support International. My name is Carrie Banks, and I grew up in a small town. Sorry, I'm going to cry. I grew up in a small town in the Southern Appalachian Mountains of North Carolina. And the reason I'm getting emotional is because my hometown was really impacted by Hurricane Helene last month. And because of that, it's kind of hard for me to talk about home right now, but I'm getting it together. And Hurricane Helene really kind of spotlighted what's so great about rural America and the community coming together and everyone knowing everyone and everyone checking on everyone. And so that's part of the beauty of what I love about rural America. When you're having mental health challenges, though, it can also be kind of the double-edged sword of rural America, where there can be quite a bit of stigma around mental health challenges and a lack of privacy around accessing treatment and support. If there's one therapist in town and people see your car in their parking lot, everyone knows you're at therapy. But I'm really happy to be here and happy to share my lived experience with perinatal. Perinatal is the time period between pregnancy and postpartum, so it's really all of the time around childbearing. We use the term postpartum a lot and postpartum depression, but it's really more than that. These symptoms can start during pregnancy and can continue for quite a while after. So I may be using the word perinatal, and I want folks to know what that means. I do also want to give a little trigger warning around my presentation, because I will be talking about suicidal thoughts. And I will be talking about intrusive thoughts, which are thoughts of harm coming, in this instance, coming to my baby. I will say my baby's totally fine. None of my intrusive thoughts came to pass, but just want to let everyone know that I will be discussing those two possibly triggering experiences when I talk about my lived experience. So my first pregnancy, I was kind of prepared for postpartum depression. I had heard of it. I'd had a couple friends who'd gone through it, and I myself had struggled with depression off and on since puberty. And so I kind of expected to have postpartum depression and was trying to be proactive about it. Went to see a specialist who specialized in perinatal mental health to kind of meet her and let her see what I was like at baseline so that if I did start having mental health challenges after I delivered, that she would kind of know who I was before having the mental health challenges. Had a normal pregnancy, and then things changed a little. I had a precipitous labor, which means it was very fast. It was less than 4 hours start to finish, which is quite fast for first labor. And for me, it was traumatic. And for my husband as well, it was a traumatic labor and birth. And I mentioned that because I do think it impacted my mental health moving forward into postpartum. When my son delivered, the NICU team was present in the room because we were worried about his health. He did not go to the NICU. They determined that he was healthy enough to stay with me. And so he stayed in the room with us, but he had a little squeak. Every time he breathed in and out, he had this little sound. And he was seen by lots of doctors in the hospital. It seemed like everyone was coming by to see my baby. His name's Johnny. He's named after my dad. And so everyone, it felt like lots of specialists and doctors were coming in to see Johnny. And before we were discharged, he did also have a chest x-ray. So already kind of setting me up to be really worried about his health, and the traumatic birth also kind of setting me up to have some mental health repercussions. We were sent home after the chest x-ray, and we lost power. There was a snowstorm and we lost power in our house. It was March. So we were very worried about how we were going to keep our tiny little baby warm. And that night as we were going to sleep, I remember he was in a little bed by my bed, and I was looking at him, and I turned my light down. I had this little dimmer, and I turned my light down as far as it could possibly be so that the room was really dim, but not completely dark. And I said goodnight to my husband, and he said, well, aren't you going to turn the light out? And I said, if I turn the light out, I can't see him. And he said, but you'll be asleep. And I remember thinking like, oh no, I won't be. Like, I'm going to be here all night watching my baby, because I was already really starting to have a lot of fear and anxiety around his safety, and feeling like I needed to stay awake and be present to keep him safe. I did not sleep much that night at all between the feeding and the fear. Sometime near dawn, I did fall asleep for a little while. And when I woke up, I realized that the little knit hat that we had put on my son to try to keep him warm without power had slid down over covering his face. And I panicked. I really panicked. And he's fine. He was totally fine. But my reaction was very big. I had a panic attack and cried a lot and was just very scared. And it wasn't me. Like, it just didn't feel like me. My mother recognized it was unusual. My husband recognized it was unusual. But also, I had just given birth and hadn't slept for 3 days. And so we kind of went on with the day. The power came back on. And that night, as we were all talking about going to bed, I told my mom and my husband, you two go to bed. I'm not sleepy, which was a total lie. I was completely exhausted, but I was too afraid to go to sleep. I had started having intrusive thoughts of harm coming to my son. So those are scary, unwanted thoughts. And everything felt like something that could harm him in our house. And I felt like I needed to stay awake and watch him and be with him in the night while he was sleeping. So that's what I did. I stayed up and I watched the Hallmark Channel all night long. I think it was Golden Girls and Designing Women, and I can't remember, whatever Hallmark showed me. I watched it all night long. And in the morning, I handed our son off to my husband and went to bed. And I think I slept for about an hour and a half. And I woke up just completely drenched in sweat and having another panic attack, afraid that he was hurt. And I think my mom and my husband both realized that something was wrong at that point, but I was heavily in denial and, saying I was fine. But I was starting to rapidly lose weight. I was not able to eat. I was barely sleeping. And almost every time I would sleep, I would wake up in one of those panic attacks. So I started to associate sleep with panic, which made it even harder to fall asleep and stay asleep. Throughout this time, I was going to the pediatrician fairly often to have my son's health checked on and his weight. I was trying to breastfeed and it was not going well. I was also seeing a lactation consultant, and at no point did I think I'm going to stop, trying to breastfeed. It's too hard. It's too much. I just kept going. And at about a week postpartum, it was exactly a week postpartum, I was so ill that I really couldn't function anymore. I was shaky all the time. I could barely, walk from the couch to the kitchen. And so I went back to see my midwives. And I had a postpartum hemorrhage, and they thought that I probably needed a blood transfusion. So they admitted me into the hospital and they started to run labs, and my labs came back just barely kind of over where I would have needed a transfusion. And I remember the midwife sitting on my bed with me, and my mom and my husband was there, and she put her hand on my leg and she said, "Your problem is not physical." And in hindsight, I can look back on that, and she was trying to tell me that I was having a mental health crisis, but she did it in such a roundabout way that I really didn't understand what she meant by that. And I felt like a faker almost, that like I was trying to get attention, or it was an awful feeling. And she said, "I looked at your chart and I see you've seen this mental health professional who also worked in the hospital, and I've made an appointment with you for you with her on Monday." And I was sent home, and I had to live 2 more days like that before I saw that mental health professional who saved my life. I was suicidal that weekend, but I truly think it was because of the thinking and the fears around my son's safety that I think that saved me, because I felt like I had to live in order for him to survive and for him to be healthy and safe. So I think that saved me. But he, starting those appointments on Monday was the beginning of my recovery. I was on 3 different medications, one to help me sleep, which was a lifesaver. I started seeing that mental health professional twice a week for quite a while, and then dropped down to once a week, and just gradual step down, seeing her very often. And at about 6 months postpartum, I started going to a support group. And I think each one of those things were all really important in my recovery. I needed medication's a really personal decision that you talk about with your doctor, but I feel like I really needed it in order to function and survive. The therapy was really important for me to understand what was happening to me. And that peer support with the support group was so important, because I needed to meet other moms who had been through similar thoughts and fears. And that really, even though my therapist had been saying, like, "You're not a bad mom, this is an illness, this is something that you're recovering from," I didn't believe her really until I met other moms who told me similar stories. So about 2 years postpartum, I started volunteering with Postpartum Support International, and started working there in 2017, and I've worked there ever since. And I truly love it. And as an organization, we provide a few things. We provide trainings for professionals, and we provide peer support for parents who are needing support. And then we connect the two. So we help parents find providers who have had training in perinatal mental health. And yeah, I love my job. I'm so glad I'm doing it. It was a horrible experience, but I'm glad it led me to where I am today. And I'm going to pass it over to Dr. Callins. Thank you all so much for listening to my story, and I'll be back in a little while later to talk more about Postpartum Support International and our resources. Dr. Callins.
Thanks, Carrie. Good afternoon, everyone. And I wanted to just, first of all, say thank you to Real Minds for inviting us to participate today. Thank you for joining. And Carrie, thank you so much for setting the groundwork for a very important discussion that we're having today. And I appreciated your warning for those in the audience who may be a little bit triggered by that experience. But I want to just acknowledge publicly your authenticity and just your willingness to share. And I will say that I think working toward advantage and talking about mental health and behavioral health, that's probably a positive thing that came from the pandemic is our willingness to squash the stigma regarding acknowledging how our mental health and our behavioral health impacts everything around us. And so thank you for that. So just a little bit about myself. I'm an OBGYN. I am in the Peach State of Georgia and have always worked pretty much in rural communities. I'm a National Health Service Corps Scholar for those of you who are familiar, and have always had a commitment to work in underserved and under-resourced communities, and have really been very happy to help connect patients to resources. I want to start out with a quote that I love, and I'm going to share my screen. I can figure out how to do this. But the quote that I want to offer is, when moms dazzle, everybody shines. And I think that what happens is if we can just start with a thought process that if our moms have exactly what they need, if our moms feel well, then they will be able to do all the things that they need to do, which is taking care of their babies and taking care of their family. And so that's kind of the way I wanted to start the conversation. The other thing I wanted to talk about is the importance of the circle of care. And Carrie mentioned being able to talk to her OBGYN, but I also want to start off by saying that everyone in the community is an integral part of that circle of care, or the term that's being used a lot now is the cocoon of care that we use to support our moms and help them through that initial period. Postpartum depression actually can start anywhere from 1 to 3 weeks after delivery, but it can extend up to a year. And so you may have a mom who has been doing well, and over time, she starts to not do well. And so it is important for us to be able to continue to check in with our moms. And if you think about it, if things are happening almost a year outside of delivery, those patients or those moms may no longer be under the care of an OBGYN, so to speak, but they may be interacting with a pediatrician. They may have had a doula for their postpartum care and what that they're following up with. They may have a family physician team. And so the awareness and the responsibility that we have as a community really belongs to everyone, because the entire healthcare team is going to be a part of that. So I wanted to start out again with offering this opportunity for us to think about postpartum depression. And it's Breast Cancer Month, Awareness Month, and so I'm going with the pink for that reason. But think about the benefit of a life jacket. When I talk about postpartum depression, I always tell my patients when we talk about whether or not we need to initiate either therapy or some kind of medication, you wear a life jacket when you're having a hard time staying afloat. You probably know how to swim, or you're learning how to swim, but sometimes you get hard and it gets very difficult. And to keep you from going under, that life jacket helps to keep you focused and coordinated. And so when I think about this discussion regarding postpartum depression, I like to talk to my patients about, I think we need to use a life jacket. And when you feel better, we can take that life jacket off. And that's exactly what happened with, Carrie. She was able to get the help that she needed, and she was able to continue to be an integral part of her family, and she was able to take care of her baby. So when we think about postpartum depression, sometimes postpartum blues is sometimes confused with that. And sometimes moms feel down and a little bit depressed and feel like they have not slept and they just can't manage a lot of things. And that's not unusual. But when we think about postpartum depression, we're starting to think about intense feelings of depression, despair, and anxiety that are not only present, but are also impacting the ability of that patient to do their regular activities. And so when we start to notice those changes, that's when we're wanting to get our moms to reach out to us if we recognize that, so that we can do the appropriate assessments that will be helpful. So I have here a couple of assessments that you may be familiar with. The Edinburgh Postnatal Depression Scale. There's a PHQ-9, a lot of them embedded into the electronic medical record. The Mood Disorder Questionnaire, the General Anxiety Disorder assessment. And also, I'm not sure how many people are aware that we're starting to also use the Primary Care PTSD screen to look at how PTSD may be impacting our moms. And lastly, if you're not already familiar with the Barkin Index of Maternal, I think that's worth searching, and when we send out the information, we'll have links to that. But that's another important opportunity for us to really exactly identify are influencing mom in her usual environment. So I have a couple of assessments listed here, and the ones that I reference are kind of the top. And this is kind of a busy slide, and I did a screenshot on purpose because I wanted to have that information just to kind of see how it works. But this assessment tool gives you an idea of how to really, if you do multiple assessments, how to help decide what category in terms of what we need to do for the patient in terms of treatment, and whether or not we're going to start with therapy or we need to go ahead and start with medication, or if it's more severe and we need to do some more immediate intervention. And so this is just an example of what some of those workflows look like in terms of being able to do the assessment. In addition, I wanted to talk about treatment. So of course, talk therapy or psychotherapy is actually something that is very reliable and very helpful. That can happen on a one-on-one basis, but it can also happen in a group, and we'll talk a lot more about resources shortly. And so being able to really accurately categorize that. But the other thing that's really important, we will never get away from the importance of really connecting with a patient. So I have patients sometimes who will complete the questionnaire, the PHQ-9 or the PHQ-2, and they are negative for everything. But I walk in the room, and if I know them and they don't look the same, they don't sound the same, they're not used to being, then that's an opportunity for me to say, you know, what's really going on? Let's redo this assessment. So feel free when you're interacting with patients. Sometimes, again, that stigma of if I say something, you know, how's that going to impact my relationship? Are they going to want to take me away from my baby? And so really wanting to make sure that you're connecting with that patient. Now, from the rural perspective, I want to speak a little bit about that, because when it comes to access to resources, and I think the things that we'll share today will be helpful, you know, if you do identify it, what if you don't have a therapist in your town? How do you get the help that they need? How do you get that care quickly? So we'll go through a lot of resources that are available. And our goal today is for you to walk away with some more tools in your toolbox, but also to just really inspire your discovery to see what else may be available in your state, in your community, that can be also helpful. And so one of the things that I like here is the assessment of risk of harm to baby. And as Carrie shared, she was very concerned about what might happen to her baby. But one of the questions that I will jokingly ask my patients is, you know, do you think you're going to throw your baby out the window? And most people should completely laugh at that thought and find it to be very absurd. But, you know, babies get very colicky and they cry a lot, and that can be very difficult for moms, especially if they don't have the support at home and they don't have that reliable environment. And so I think it's really important for us to, in our assessment, to be able to address that. But again, that responsibility is not falling just on the OBGYN. Actually, postpartum, moms are probably in the pediatrician's office more often. They may be seeing the midwife postpartum more often. And so anyone that has contact with the mom actually should be constantly assessing them to see how they're feeling. And then I have another slide here which talks a little bit about follow-up treatment for perinatal mood disorders. And it's for us to be able to reassess our moms and really look at what's going on in terms of how quickly are they responding. If we're doing any kind of medical therapy, we're usually expecting it to take effect usually at about 4 weeks. And so really making sure that we're having careful, close follow-up with moms. And thinking about options in terms of medications, we do have, there are a lot of antidepressants that many people are familiar with and may have even taken in a previous pregnancy. But we do now have available a medication. It's actually a newer steroid antidepressant. It's a new category that's taken once a day for 2 weeks immediately postpartum, and that could also be helpful. So it's good to see that there are new things that are becoming available to manage that. Now, in terms of statistics, the one thing that I did want to mention today very briefly is that, you know, in 2022, the CDC got a report said that mental health disorders, especially related to postpartum depression, substance abuse, is now the #1 reason for maternal morbidity. That's huge. So this conversation today is very important. And what we want to make sure of is that our patients' outcomes, how well our patients do, how well our communities are, is not determined by where our patients live. So whether or not they're urban or rural, we want to make sure that they have that appropriate access. So I'll just briefly start going through a couple of resources as we get into our next segment. I am in Georgia, and so I wanted to just share kind of what some of our resources look like. I'll just specifically mention Peace for Moms. That's a line that you can call. Any provider across the state can make a phone call on what's going on with the patient, and within 30 minutes, a psychiatrist will call you back and walk through what you need to do with that patient. So that's very helpful, because if you do have something that happens on a Friday afternoon, at 4 o'clock when everyone's getting ready for the weekend, and you do want a patient to be connected, you want them to be safe over the weekend, that's another starting point. And we'll be going over lots of different resources as we go throughout this, but it is possible that your state has something like this that may be available that they can tap into as well. The Substance Abuse and Mental Health Services Administration has a wealth of information. And I wanted to kind of put this out there because if you're not already familiar with what resources they do have to offer, I think this is worth delving into, because again, what we want you to do is walk away from this opportunity today, understanding that postpartum depression is something that we need to address, but knowing how to address that, to know that it is something that we can treat, to know that we can actually really help our moms do better so that they can take care of their families. Also, we have additional information here. There is a 1-800 line that you can call. It's 833-TLC-MAMA, and this is the Office of Women's Health. This is another resource, if you're not familiar with. It's a great opportunity, again, for that 24/7 confidential support for pregnant women and also for new moms. This is a website that I came across, and I think pregnancy loss, there's so many things that can impact what happens with mom. An unexpected outcome or change in the type of delivery she's expecting, to have a vaginal delivery and it gets converted to a C-section, or mom develops, preeclampsia, or some unplanned event. Any of those things impact on mom. But also pregnancy loss is something that we really need to pay just as much attention to, because especially if it happens when mom is term, she may actually start lactating, but she has no baby to feed. And so really being able to support her during that time is really important. So this is another great resource. The CDC has a wealth of resources as well. And I'll just kind of put this page on here. If you've not looked at the CDC resources, I would highly recommend. They do have specific resources for postpartum depression. The Mayo Clinic has a really amazing depression medication guide. Actually, one of my students introduced me to this just yesterday. He's getting an opportunity to go through and look at your symptoms, to look at adverse effects that you're concerned about, whether or not you're breastfeeding, to really help guide medical therapy if that's appropriate. And also the National Child and Maternal Health Education Program has lots of resources dedicated just to moms and to mental health. And of course, HRSA, this line I've mentioned before a couple of times. And I wanted to end with this national network of perinatal access programs. So if your state is not highlighted in green or blue, then there's an opportunity for you to reach out to them to see what's available in your state. Again, our goal is to really improve and advance health equity, to make sure that all of our moms, regardless of where they live, urban or rural, that they have access to the care that they need to do the best for their families. And so this is another resource that's available if you're not already familiar. And so with that, I'll turn it back over to our moderator, Julie.
Well, thank you, Dr. Callins. That is a wealth of information, and actually you addressed some of the questions that we're already receiving from people in the audience. Is how do we find this help? And it appears that there's a lot more resources than maybe a lot of us imagined were available. And as you said, you have some specific resources there in Georgia, but there's also ones that are available nationwide. And maybe if somebody wanted to find out what was specific to their area, how would they go about doing that?
So that last slide that I highlighted, you can actually do a search by the state. There's a link that goes forward, and they actually have a link for each state. And if the state does not have resources, there's a number to call so they can help you identify what may be available. And so I think the last couple of slides actually were things, a lot of the lines were about their 1-800 numbers, so anybody can call and they can get access to that. And I'm sure Carrie wants to add on to that as well.
Yeah.
Absolutely. And Carrie, I was going to ask you because, one of the things that you mentioned, and I think we hear in so many different situations when it comes to people who are dealing with some kind of a mental health issue or a mental health crisis, is they feel like they are the only person who is going through this. So I think the peer support that you talked about, we would love to hear more about what your organization offers and how this helped you.
Yeah, absolutely. So yeah, Dr. Callins shared some amazing information. If your state doesn't have a psychiatric access line, Postpartum Support International does have one that serves all states in the US. So you can certainly call that. That is a number for providers. For help seekers, for parents, we have a helpline number, which is in a slide I'll show a little bit later. You can also reach out to the National Maternal Mental Health Hotline, which Dr. Callins shared a couple of times, that TLC Mama number. And PSI is a partner with the National Maternal Mental Health Hotline. And if someone needs help finding therapy or a medication manager or a doula or lactation support, they will actually refer them to PSI. And we have within our volunteer network, volunteers in every state that has kind of a geographic area that they are assigned to. And if a caller or texter calls in and wants help finding support in that area, we kind of transfer it to the local volunteer who will talk them through their options. And they'll talk through things like, do you have insurance that we need to keep in mind? Do you have transportation issues? Do you have access to internet? Is the race or ethnicity of the provider important to you? Those are the kinds of questions that we ask to try to get them a great match that's really going to help them recover.
I get an interesting question here from one of our viewers, and they wanted to know about the healthcare professionals, and I think also maybe the volunteers in your organization. How are these people? Are they all trained specifically to deal with postpartum depression and with issues relating to childbirth?
Dr. Collins, do you want to talk about kind of your perinatal mental health training, and then I can add on?
Sure. So I think one of the things that's interesting to note is that now that perinatal mental health has become such an important part of the fourth trimester, what happens after, we do have a lot more access to training for us to be able to do the appropriate assessments, but also to initiate the appropriate treatment. But as an OBGYN, definitely not trained in psychiatry. And so being able to be in a network where you do have that access. So I work with Community Healthcare Systems, which is a federally qualified health center network that's in Central Georgia. And we have multiple clinics, actually 18 clinics throughout Central Georgia. We do have a behavioral health team. And so one of the nice things about being in an FQHC network and being rural is if you do have the benefit of having that rural health access, your patients actually have an advantage because I can initiate the assessment, I can even start medication, and then I can work on the follow-up. And so there's no gap in that care. And so it is really important, especially in our rural communities, to utilize those existing resources. And for the cases where I don't to a behavioral health specialist and I feel like I'm uncomfortable, then I'm usually going to be calling that line where I can talk directly to a psychiatrist. And I'll just give you a brief example. I had a patient recently who was having some issues postpartum, was on a particular medication, a smaller dose. I called them because I was concerned about her baby was in the NICU, as you mentioned, and a lot of unexpected things, and baby not doing well, and baby turning around, and mom going home, and baby going home. But in the conversation, a higher dose of the medication caused some side effects that were not tolerable for the patient. And so they recommend, instead of just doubling the dose, just adding an additional half dose of what she was taking before. It was magical. Okay. And that's not something I would not have thought of because that's not my usual practice, but it was really good to have that advice. And so I could make that medication change. And within a couple of days, it was much better. So that's an example of recognizing when your training is not adequate, but what your patient needs. And I think everyone on this call has that same mindset where if I cannot provide it for my patient, I'm going to find someone who can help me find it for my patient. And that is the kind of enthusiasm that is going to make a difference in our communities, where we will make sure that they are connected to what they need if we cannot provide it.
Absolutely. Carrie, how about your organization?
Yeah, so part of Postpartum Support International is our state chapters program. And I saw in the chat earlier, someone from our Tennessee chapter is here. Hello. Thank you for being here. And our state chapters are really masterful at finding deserts where there may not be any perinatal mental health professionals, whether it's therapists or psychiatrists, and really working on the ground to fill that gap with scholarships or with trainings coming into that area. So we really take very seriously trying to fill those gaps state by state. And I would say all of our state chapters have probably like a rural committee, or part of the scholarship program is ranking folks on things like languages spoken, rural, versus urban. Is it a BIPOC provider? Things that really matter for us in terms of access to care. And that's been really important. We also have a provider directory that's online that anyone can search. So parents can go onto it. If you just Google PSI directory, it's similar to Psychology Today, but the really important difference is that everyone in that directory has had advanced training in perinatal mental health. It could have come from Postpartum Support International, or it could have come from any number of other organizations that have a similar kind of 12 to 14-hour training. And that way, that you're actually talking to someone who has had some advanced training in perinatal mental health, because we do unfortunately have times where bad advice is given, or concerns are diminished as it's just the baby blues, as we talked about earlier. That's not always accurate or helpful. So it's really important to find someone who has that perinatal mental health background and training.
And Julie, I wanted to add.
No, go ahead.
I've not mentioned PSI a lot, even though we utilize them because Carrie's here, and so I'm letting her do that. But they have an amazing initiative to educate the community, and they've actually come on faculty at Mercer School of Medicine, and they've come and they've done. And so there's something very empowering about how we educate the community to support our moms. And PSI, that is actually one of their initiatives, and that's one thing that I think is very helpful in moving forward, how it's addressing needs for our moms.
Okay, so it's making sure that everybody knows the situation, not just the people that sadly are dealing with it and going through it themselves. Carrie, you mentioned something I wanted to go back to, because it's how do you know, when is the tipping point between, okay, this is the baby blues that may be typical that moms might go through for a short period of time after giving birth, and when it is truly postpartum depression and something more serious?
Yeah, so when we train on this, we talk about a few different things. We talk about timing. As Dr. Callins mentioned, the baby blues are typically in the first 2 weeks. And it's things like crying during a sappy commercial, but your overall mood is happy and you are enjoying life. So that's the timing piece of it, typically in that first 2 weeks. Severity is the other piece. I was in my baby blues period when I was having my mental health crisis. And I actually think that was part of the reason why I didn't get care earlier, because people were thinking, oh, it's the baby blues. But the severity was such that it should have been realized that I was having a mental health crisis. So I would say the person's ability to function is a really important thing to look at there. And I'm sure Dr. Callins can add to that.
So I'd just like to add, I know we don't have a lot of time, but history and also hormones. And so if there's a history of having a mental health condition, if there's pre-existing depression, if there's postpartum depression or previous pregnancy, that's something that I think is really important to keep in mind. And then knowing that there are hormonal fluctuations that do accompany the postpartum period, and that is a part of it. But again, that tipping point is their functionality. And so if they're not, and I have patients who've come in and I can tell they have not combed their hair, okay? They have not taken a shower. And all they can do is just maybe take care of the baby. And so I usually ask, are you able to do your usual activities? And if they cannot do that, if their anxiety or their depression or their sadness is impacting their ability to interact with their family, or even do self-care, then that's a concern. I also think it's really important to ask the hard question, have you thought of hurting yourself? And you run the risk, of course, of, wide-eyed, but I've gotten more comfortable with asking that question. And when the answer is silence, then we can really move forward. And that helps us also to activate the plan. Sometimes I have them make that call while they're in the office with me, because I need to make sure that connection happens. And I'm not saying, hey, here's 988 and call them when you get home. We're doing it in the office. So that way we have to build that safety plan. And I like the term safety net, but if anything on net, it's not very comfortable. And so I'm starting to use the term safety hug. How do we start to envelop that mom with that safety hug? What do we put in place for them? And I've had patients on Friday, and I will call them the next day. Did you pick up your medicine? And then I'll say, did you take your medicine? Is someone at home with you to watch actually sleep tonight so you can get your first dose in? And so it's going that extra step. And a lot of times, believe it or not, our rural communities are probably going to be easier sometimes to offer that kind of safety hug, because it's just a different environment. And so that can sometimes work to the advantage once we recognize that we have to expedite that access to care.
People are very used to helping each other, and it's just getting to that point. Do you have many patients who you feel like they're either in or close to postpartum depression who are reluctant to have treatment? That they're, especially we know in rural communities, people tend to be very self-sufficient. So do you have patients sometimes who you have to convince, and how do you do that?
So it does happen, and it happens for a lot of reasons. Sometimes it's related to their faith. And there may be a reluctance to sharing information or to even taking medication. Sometimes they're admitting that something is going on, but honestly, trust. Can they trust the person that they're talking to? They will not be ridiculed. They will not be made fun of. That information will not be shared. As Carrie mentioned, if you go to the mental health office, if you park your car, everybody knows your car and your license plate. So how do we protect that confidentiality? And so there are lots of factors that would make a mom maybe not share. But I think trust, because at the very root of it all, our moms want to take care of their babies. They will forget about themselves, but they want to make sure their baby is fine. Stay up and watch, TV and be up so she can watch her baby. And so that's why I started out with saying, if mom, then mom will do what she does best. So the other thing that I see a lot that shows up is irritability. And so I call it the snappy turtle syndrome. And so I'll say to my moms, are you snappy? And they kind of look at me. And then if there's a partner in the room, they look at away. And so I do see a good amount of that irritability and anxiety that shows up too. And sometimes people just really think, well, I haven't slept, and so that's normal. But if you really name it, they can claim it, and then we treat it. And so I do find sometimes in those cases, a short course, that life jacket, with medical therapy can be helpful while we're working on getting them into talking in either individual with a group. And so really it's just having that one-on-one, but trust is where it all starts. And I think that there's a quote that I love that says, change happens at the speed of trust. I've actually edited, I say transformation happens at the speed of trust. And so all those fears and barriers can be melted away if they trust the clinician that they are talking to.
Yeah.
It starts with that. And then Carrie, share with your experience. I'm really interested. You said you went from one-on-one talking with a therapist, then to this wider support group. So how did that evolution work, and why was the peer support group so important?
Yeah, well, it's kind of interesting because I came off mute to say the opposite, in that a lot of folks who are reluctant for therapy or reluctant for medication, they may come to a support group or they may call a helpline. And particularly our support groups are great stigma busters because you've got a mixed group there of folks who it's their first group and folks who it's their 15th group. And you see folks who are in different places in their journey, and you meet people who were totally against medication, but now talk about what a helpful tool it's been for them, or people who are totally against therapy and now like love their therapist and can't imagine ever stopping going to their therapist. So for me, I think I kind of actually went about it backwards because I had that pre-existing relationship with the therapist because I had those risk factors that Dr. Callin was mentioning. I had that history. I knew I was at risk. And I could face talking to her one-on-one, but it was about 6 months postpartum that I actually felt safe leaving my child home alone
Oh,
to go
wow.
to a support group and meet other people. And now they're all virtual. This was, 11, 12 years ago. But now we have people joining support groups at, 2 days postpartum, which I could have never schlepped my baby into, the support group at 2 days postpartum. It couldn't have worked. But because they're virtual, we're reaching people earlier. And, the facilitators fade back into the background and they're talking to one another and they're supporting one another. And I think that's so incredibly valuable.
Absolutely. Absolutely. And again, like sometimes we hear it so often, people thinking I'm the only one who's dealing with this problem. And just sometimes knowing that you're not alone can make a difference. I want to go to some of these questions, even though Patrick's sending them to me in such small type, I can barely read them, but I'll do my best here. Somebody wants to know if and I think this could apply to both therapy or to groups, is it different and does it need to be different for women in rural communities simply because they may be dealing with each, and Dr. Callins, you talked about this busting the stigma. So do you think that there is a need, is there a need, or are there groups that are specifically for women that live in rural communities?
So I think with everything that we do in terms of mental health or just healthcare in general, really needs to be individualized. And so we really need to be considerate of environment and sometimes even the family. I've had patients, for example, who have refused to take blood because that was not part of what was allowed in their family. That was concerning for them. And so I think that it is important for us, again, to use that trusting relationship. But I want to add another thing. So let's just say the patient that we're interacting with maybe did not have the benefit of establishing prenatal care, and she's showing up and she's now delivering and does not have a trusting relationship or had a previous something that impacted her ability to seek care. So then the clinician now is responsible for repairing that bridge and rebuilding that trust. And so sometimes it's creating it because it needs to happen, but sometimes it's also the fact that something happened differently, and so we need to be able to reestablish it. And so again, it's that individual here and making sure we're figuring out what kind of baggage, so to speak, is a patient bringing, and how do we unpack that, and how do we help them sort through it so we can get them to the care that they need. But honestly, I think that knowing what's available is important, but the advantage of, for example, calling the hotline is there's that anonymity. If you want to talk to someone, but you're not worried about talking to someone that you may see at church or at the grocery store, then you do have that. And so I think there's a freedom that comes with having access to that. What I've started doing with patients who are initially resistant to my recommendation to seeking help, I'll have them save the number in their phone. And I say, you know what? You may have a friend who needs this, you may not need it. But if your friend calls you and they need some help, you have it. So what I've done is not only have I educated that patient, I've also empowered them to maybe do it for themselves later on. But people love the idea of helping other people. Again, this is kind of how Carrie fell into her dream job. And so I think we can capitalize that on that as well.
Interesting. Yes, absolutely. We just keep getting so many great ideas that people can use. I did have another question that we really should talk about a little bit, and that's the role that a father or partner can play in the person the woman who's dealing with postpartum depression. How can they provide support?
Carrie, you want to go first?
Yeah, thank you. So this is not an issue that only impacts, birthing parents. Dads are impacted at a rate of around 1 to 10. Adoptive parents are impacted. Same-sex couples are impacted. It's an illness of the whole family, really. And a lot of times we see when the mom starts getting better, the dad starts to have depression or starts to have anxiety. And so they both often, if one is suffering, they have an even higher chance that the other is also going to be struggling with their mental health. We have support groups for dads that run every single week. We have a queer and trans support group. We try really hard to make spaces that are accessible and brave for everyone, really. And I want to mention too that a lot of our resources are available in Spanish and English, including our helpline and our support groups, because it really is. I mean, we have grandparents that call who say, I struggled with this and now I see my daughter and we've never talked about it. And should I tell her? And I mean, it really is, it impacts generations and everyone in the family. So yeah, it's important to ask, how's your partner doing? How's the rest of the house doing? How are your other kids doing? Because moms are the heart of the home in a lot of families, and when mom is struggling, the whole family is struggling.
Absolutely. Keisha, would you like to add to that?
Yeah, I second everything. It definitely impacts the family, and it's important that as we think about our management and our treatment options, that we're not just focused on mom, because everybody is impacted. But I wanted to just add also the importance of our assessment. The Barkin Index of Maternal Functioning is really important, and looking at how we assess using, for example, our Prepare questionnaires that looks at social drivers and things of that sort. There are a lot of things that can impact what happens after you deliver. So let's just say we have inclement weather and then there's no power, or the car breaks down, or any number of things. And so really being able to, there are some things that are fixable that can help support mom and impact her mood. And so being able to, in a safe space, find out what those things are. Is it that they have food, or whatever it is. So being able to doing our assessment to focus on those fixable things that can be addressed by maybe connecting with a local church or a local food bank to resolve that immediate pressure if something has happened at home. And so I think really we look at, we think about mom as the center, and no offense, but she is the sun and sometimes the moon too. But then you think about what happens, what's around there. You think about the partners, you think about the dads, you think about the grandparents, but then you think about the environment. And so one of the things that's really critical for us as we address our mental health concerns in our postpartum moms, our perinatal period, is really that assessment of the environment. And then also too, not waiting until after delivery to start that conversation. So I had a friend recently, and I talked to her about signing up for, a grocery delivery system, or having someone deliver groceries, and like figuring out what that would look like. So that's like one stressor. And so we do have to be mindful of how those stressors can impact things, and what we can do in advance to kind of help with that as well.
So kind of start to pave the way so that you can lessen some of those stressors when the time comes, when you'll have plenty of other things to focus on. Awesome.
And it'll help that
Carrie,
too if we do that.
Absolutely. Carrie, I think you had some more resources that you wanted to share, and we want to make sure we do that while we have time.
Thank you. I'm going to share my screen and show just a few resources from Postpartum Support International. Of course, that's the wrong slide deck. Let's see. Okay.
So there you go.
Okay, we touched on this a moment ago, but just wanted to bring home too, like how prevalent this is. A lot of parents are going through this. So the resources that we have for parents, I really encourage folks to check out our website. It's postpartum.net. There's a couple great sections there. The Get Help is all the information I'm about to go through, and then the Learn More talks more about the different types of illnesses. So there's the helpline that we've talked about, available in English and Spanish. You leave a message on that line and one of our volunteers gets back to you within 24 hours. It's usually within about 3 hours, but our guarantee is 24. We do, as I mentioned, help people find support in their local area. That's our support coordinators program that feeds right from our helpline into that program. Our provider directory is searchable, and you can look for specialties, you can look for insurances, you can search kind of like TripAdvisor or some other types of websites where you just search for what you're looking for. It's really handy. We have lots of online support groups in English and Spanish. And we have this also for loss. We have a huge menu of loss support groups for pregnancy and infant loss as well. Our peer mentor program is great, and a lot of rural folks access that. You can do it by text. You don't necessarily have to have high-speed internet to access our peer mentor program. And so someone who is currently struggling will be matched with someone who is recovered, and they walk through that hand in hand and talk at least once a week. We also have our chat with an expert. These are done on kind of old school conference lines. Every first Monday of the month is for dads, and then every Wednesday is for moms. And those are led by mental health professionals that you can call in and ask questions of. And then we also have a forum that you can create a very private name, like you could be Aardvark47 and go in and talk about what's going on with you. So lots of privacy in that Smart Patients forum. And you can follow us on social media. We would love to have you. We also always share the emergency resources. I saw that you had 988 in your welcome slide. We also share the crisis text hotline, which is text home to 741-741, and the domestic violence hotline as well. And then finally, again, this is just the National Maternal Mental Health Hotline one more time. This differs from our helpline that I talked about just a moment ago, in that you get in a line and a counselor is going to answer your call as soon as they're available. So it's usually a few minutes wait for calls and texts, and you get help right then, even if it's 3 o'clock in the morning on Thanksgiving.
Oh, wow. But that's available nationwide.
Everywhere
So-
in the USA, and including military members that are stationed overseas.
Oh, wonderful. It's great to know, because frankly, I didn't at the beginning of this know that there are so many resources out there that are available. And we will, and I'm sure that our folks have talked to you, share these resources with Rural Minds so that we can have them on our website as well. And of course, this webinar is recorded. So anyone watching, if you know someone who would benefit from this terrific information, then it will be up on our website in just a few days so people can access it and watch it if they weren't available to be with us live and in person this evening. But as we wrap up here, ladies, I'm going to ask each one of you, and Carrie, since you're on the screen, we'll start with you. Just kind of talk a little bit about what you'd like to see, what's not available right now, a resource or a change in behavior when it comes to postpartum depression that would make things even better for all of the women that are dealing with this, which you just showed us are more than maybe we had anticipated.
Yeah. Oh, thanks for the hard question. I think that there's always a need for more. I mean, we have 30 groups a week and they're full with a wait list, but we always need more. We always need more topics. We always need more space, more volunteers. So I just want to see the awareness continue to grow, the stigma continue to decrease, and people reaching out for the help they need and deserve.
If someone wanted to volunteer, wanted to learn more, can they do that by going to your website?
You can, yeah, postpartum.net. And then I think it's Join Us is the navigation.
Awesome. Thank you. Okay, Dr. Callins, what would you like to see in a perfect world? What would you still like to see change to help the mothers that are dealing with this situation and their families?
So thank you again for the hard question. If I had my list and I could get whatever I would want for our patients, number one, and it's two things, so I'll be quick, just making sure that we're always keeping the patient at the center of everything that we do. And if you do interact with a patient and they're not ready to make that move, then being patient with them and letting them know that they can come back around. They have not missed that opportunity to share. And I've had patients who have left and called later and said, I didn't tell you the truth. I want you to help me. And said, okay, good. So that means that, we don't win all our battles the first time. And so just keeping the patient at the center of everything that we do. The second, and I think is this thing that the community can help with, would be, how do we increase our touch points for how we interact with our patients? And so are we utilizing all those opportunities? So are we assessing moms in the prenatal period so that we are looking for those risk factors and being able to prepare moms who we know had a concern the last time and may need to be on medication in the third trimester so we can help her transition? But also too, after mom delivers, mom is going to pediatrician. And so making sure that the pediatrician or whoever they're seeing, the family physician or the doula or whoever's doing the home visit or whatever entity is interacting with that postpartum mom, being able to keep their radar up and making that connection point. And I think that when we look at where our maternal deaths happen, the majority of them are happening, especially in the state of Georgia, from actually 6 weeks to 365. Those patients are not really in regular care, so where are they? So if your family member is not in your text message and you don't see them at church with their kids, or the kids look like they're disheveled, or the dad looks like he's losing his mind, any of those things, but just really every opportunity that we have to connect, we really need to be reaching out and looking and helping people to really connect, to let us know how we can help them. And I think we can do that better in our postpartum management and our care.
Thank you. Unfortunately, I have to stop you now because we are running out of time, but we do want to thank both of you, first of all, for this wonderful information, our good friends at the National Grange, Sage and Biogen for their sponsorship, and for everyone watching, we have a survey that will come up after this webinar concludes. This is how we get our topics for future webinars. So please take a moment, complete the survey, and thank you to everyone for being with us for this very interesting and informative webinar. And now we wish you all a very good night.